I'm really excited to be able to present for this track, and we are in the Transitioning Care, the Pediatric to Adult Healthcare Providers, and it is being put on by Amy Miller. And so for the sake of time, because we're a little bit behind, I'm going to go ahead and just pass it off to Amy.
Good morning. I think it's morning. Nothing like being the presenter right before lunch, right? So I'll make sure that I'm right on time for you all. But I am Amy Miller. I have the pleasure of being the Executive Director of the Child Neurology Foundation. And in case anyone in this room is not familiar with us, just briefly, our website's on there, and I'll show it again at the end. But we are a national advocacy organization that represents the over 400 pediatric neuro conditions that are currently diagnosed. And our aim is really to be a connective center of education and support for children and families living with pediatric neuro conditions. So be happy to stay afterwards if anyone would like to learn a little bit more about us. But in particular, about 3 years ago, our board of directors, 51% of our board of directors are practicing child neurologists, really stood up and said, we have a tremendous gap in our service system when it comes to how we're transitioning the young adults living with these pediatric neuro conditions over to the adult healthcare system, and how can we do better. And kind of doing a survey of the community, we said the foundation is in a unique position because we are this connective center amongst clinicians and patients and families and industry, that we should take this on. So I'm going to talk a little bit about our initiative as well. But before I get into that, what I welcome you all to do is, if you've chosen to come to this breakout session because you're currently involved in a transition planning process, or you're on the other side and it went great or it went horrible, or if you're fearing what's coming for transitioning your loved one into the adult healthcare system, I ask that you just kind of release what you think you know about it right now, and instead reframe our minds to thinking transitioning our loved ones into the adult healthcare system is a good thing. When we are so committed within their childhood years to finding appropriate diagnosis, getting the right treatments in place, building that community of care, we forget that the children of today will become youth and eventually young adults, and that's a good thing. That means we are doing our care and creating this community of support successfully. But what we need to do is expect that development and that transitions to happen, and start planning for the transition so it's a smooth and successful process. When I was just in a session next door, so I was just in your seat, and when I'm in your seat, I always like to know a little bit more of who the heck I'm supposed to be listening to for the next 30 or 60 minutes, and I like to kind of always start off this and say, I'm a person that believes in any moment you're a teacher and a student, and so just because Nicole Boyce asked me to get up here for the next 50 minutes and talk to you about transitions puts me formally in the position of a teacher, but I also want to learn from you. So as we go through this session, if you have questions or want to share your stories, please feel free to raise your hand and let's have a dialogue. Where I hope the conversation goes is I want to make sure that everyone has the correct understanding of when we're talking about a medical transition, exactly what does that mean. Within our healthcare system, it's a game of alphabet soup sometimes, and we use different words to mean the same thing, and that just causes confusion. So I want to make sure we're all using the right vocabulary. I want to highlight what the foundation is doing around transitions and how that can be of assistance to you and the patient community that you're working with. If you're in a direct caregiver role, I hope that you also, through this presentation, start thinking about what are your expectations for transitions and how does that affect your current role. It's always good to leave any sort of learning session with some very practical tools that you can get to using right away, so we'll be highlighting those at the end of the session. And then again, just an opportunity to take some time to reflect, maybe as you walk across to the beautiful ocean that we sit right across from today, but knowing that we're expecting to transition these pediatric patients of today into the adult healthcare system of tomorrow, what does that mean to you and how your life or the caregivers you represent, how their lives are organized right now? There's a lot of identity in caregiving, and rightfully so, but as those patients age out and your caregiving needs may change, that can be a another opportunity for reframing one's life. Okay, so let's get started and let's lay some groundwork. So understanding vocabulary. When I'm talking about medical transitions, what I'm really talking about is transitions in general is an expected process, right? As we are expecting our young people of today to become adults, we expect that they will age out of the pediatric healthcare system. That can vary. For some hospitals and some clinicians, that's at 18. Now with accountable care and private insurance covering up until 26 years of age, some young adults aren't transitioning until then. But the actual act of medical transition is the reframing of who's that healthcare system within the pediatric context and who's it going to be in the adult healthcare system. We can't talk about medical transition without talking about social transition. And social transition is really that quality of life. It's everything about living. It's everything about that patient reaching their goals of care and living to their independence. So we're talking about education. We're talking about vocation. Where are they going to live? Are they going to remain in your home? Maybe they're going to live independently. Maybe they're going to go to a group home. But it's very important to understand that medical transition and social transition are not exclusive of each other. They have to happen aligned with each other's intent. And an example of that is really insurance, right? So you can't really access very good medical care in our country without insurance, yet insurance has age gaps, right? So if your pediatric patient is on private insurance, and let's say that coverage ends at 21, if he or she has not understood how to navigate that system to get insurance on their own, then my golly, if they have a medical crisis and they're age 22, on their 22nd birthday, they end up in an emergency room and they don't have coverage, they can't access the same level of care in the adult healthcare system that they were used to accessing in the pediatric system. When we started working on this project, we pulled together an interdisciplinary group of experts, including parents, siblings, young adults, clinicians, social workers, etc. And the amount of stories that we heard about the scenario I just told you were staggering. So we had patients telling their stories that they had worked for a decade to get their condition managed, their symptoms under control. They had this very complex cocktail of the medication that they were boom, boom, boom on. But no one talked to them about insurance or the fact that a mother who was taking care of her child that was living with a very rare form of epilepsy, I remember this story very in particular, she was always used to being the one that the physician talked to and made the decisions for her daughter's care. No one talked to the mom about guardianship and the fact that appropriate documentation needed to be put in place for her to be always the one that would be asked to make making the decisions for her daughter's care. And on her daughter's 22nd birthday, they ended up in the emergency room, her daughter in a static event, continuous seizures. And an adult provider in an adult emergency room, brand new facility, walked in and started talking to her daughter that was seizing. And when the mother said, no, let me tell you the story, and went into her usual role, that adult provider said, I can't talk to you because you aren't designated as her medical surrogate. You don't have guardianship papers. That's a scary reality. So I share that again, not to scare, but just again, as we are thinking, we know that our pediatric patients of today are going to be adults of tomorrow. So let's make sure that we are putting together appropriate transition plans to coordinate that care so those sort of situations don't happen. The last term I want to define is transfer of care. And oftentimes people will use transfer and transition interchangeably, but we're talking about two different things. The transition process, again, it's a process that happens over multiple years. It's planning for the actual transfer. If you can think of transfer as the handoff, right? It's that pediatric provider handing over the care to the adult provider. For those of you who are involved with patients that have disease exacerbations and they go in and out of the hospital, transfer of care can also be when a patient's transferring from an ICU down to a floor bed or maybe from a hospital back home. Those are transferring care, handoffs between providers. Transitions is the larger process that we're talking about. Obviously, you think transition is important because of all of the great choices of sessions to go to today. You've chosen to come in and hear more about transitions. But in the literature and for our patients, why is this so important? When we don't do a good job of planning for transitions, we do see a decline in health status during that time of young adulthood. And this is across diagnosis. This isn't just specific to one disease state. So we see rejection of solid organ transplants. We see disease exacerbations where patients are in and out of the emergency rooms or ICUs. We also see an increase in comorbidities. So, other healthcare conditions that complicate that primary diagnosis they're living with. We also see a decline in how those patients are accessing the healthcare system. So they're not taking their medications as they once were. We see them not show up to follow-up appointments, which is not surprising if they don't know who the heck they're supposed to go see. And we also see a lapse in insurance coverage, which we know, all of us know, that a lack of insurance in of itself is a barrier to accessing health care. So for us in the neurology community, and I want to just kind of highlight this, I'm going to be talking specifically and giving a case model of how things work, and I am going to be using a rare condition that has a neurologic etiology. But for those of you that are here because you have or you're representing a patient community that doesn't have a neurologic etiology, what I'm talking about is completely appropriate and applicable to your patient population. Neurologic components or symptoms can be associated with a host of rare disorders that have a different etiology, maybe pulmonology or cardiology. It doesn't have to be neurologic focus. I just kind of want to offer that to you. But for us in the neurology community, we're talking about 1 in 6 children within our country live with a neurologic diagnosis. Every year in our country, 18 million young adults are leaving the pediatric healthcare system and they're headed straight into the adult healthcare system. Our country, about 2 years ago, put out a national survey and called up patients and families and asked them, hey, how's it going with the healthcare delivery system? And in particular, they asked questions about transitions of care and if their young person was receiving transition planning services. Less than half of those respondents indicated that their provider was even talking to them about transitions. How many of you have had a provider talk to you about transition planning? Okay, about 3 or 4. Were you expecting that conversation to happen? Or were you shocked? You were a little bit surprised? Okay. It was a nice surprise, okay. Okay, and why was it a nice surprise? So the system was going to basically help you all do the transition process. You weren't going to have to go outside the transition. Okay. Okay, so they did not have a transition planning process for the pediatrician to the internist, the primary care physicians. The other specialties did. And can I ask you, you said that you were kind of shocked by the...
I've had 2 experiences, both at the same children's hospital. One was like a very smooth, I was given a list of specialists and which one was recommended for me. And then I saw enrollment after that. And the other one though was under GI, which has a really good program if you have IED.
Mm-hmm.
If you fall outside of that, they have almost no transition program. And I had 2 failed transitions and I'm still after that.
Okay. So for those of you that didn't hear, and thanks, Ashley, we'll start using the microphone as we can kind of start this conversation. But what this young lady was saying is she had one specialty provider that actually helped her identify an adult provider, and that was a smooth transition. The other subspecialty she worked with didn't really have a formalized transition process, and you've used the term that she's had 2 failed transitions. So thank you both for sharing. Unfortunately, your second experience is what the majority of our young adults in this country and their loved ones are experiencing, failure in the transition process. In particular, and again, transitions is for all young adults, whether you have a special health care need or not. Obviously, for those that have a more complex, complicated condition, the need for further coordination of their transition planning is even more profound. When we look at those that are living with seizure disorders, for example, we know that those seizures, there's a high chance that those seizures will continue into adulthood. And even more, we have to think about the cognitive impairment of young people that have lived with pediatric diagnoses that that are going to need further assistance as an adult because of the cognitive impairment that their disease state has brought on. We've talked a little bit about barriers, and I don't want to stay and be a Debbie Downer and continue to talk about what's wrong. We want to talk about solutions and how we fix it. But for those of you that are out there, you probably know these barriers much better than the rest of us. Why transitions is so hard, it's multifaceted. I like to say it's a beast because it's everywhere and everything can be all-encompassing. But some of the specific barriers that those of us that are involved in this face is the fact that a lot of patients and families work a really long time to build the healthcare team that they want and they like and that works for them within really that first decade of life. And the thought that they're going to have to give them up and start this all over again, it's totally unacceptable. They don't want to do it. And that sort of resistance can be a barrier. Especially when we're talking about rare diseases, these diseases, because of the advancements that through collaboration that like ours, these children are living now into the adulthood more than ever before. Yet we have these adult providers that when they were going through their training, never even heard of these rare diseases, or even those diseases that are diagnosed. A lot of them didn't even know about them, didn't know about the treatments. So we have if you think about it, we have a community of providers that are set up to catch these incoming young adults, but they have no idea about these conditions and how to manage them. There's a big difference between the pediatric adult healthcare system and the adult healthcare system, meaning the pediatric healthcare system, I'm a ped nurse practitioner by training, we're taught to talk to the whole family and how to balance working with families and the patient. The adult healthcare system is totally patient-focused, right? And they have a hard time thinking about how to prepare and work within a family system in the deliverance of care. We've talked about the insurance changes, and the other aspect of barrier or an access to barrier is really just transportation, and you're going to see this within the case study. But how do we get these young adults actually physically in to see healthcare providers if they aren't able to drive or don't have the means to even access public transportation? So an example of that is some families, when they're utilizing the pediatric healthcare system, can use Medicaid-covered transportation services to and from doctors. I don't know if anyone here utilizes those services. That's very helpful. It's a community support that our pediatric patients have. That goes away often when you're an adult. So how do we still transport these patients? It's obviously important. All right, so let's start talking about what we're doing to get ahead of this. First of all, back in 2009 because of that national survey that came out that said less than 40% of our youth today are even being talked to about transitions, the membership bodies of the main primary care physicians got together. So I'm talking about the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians. Those are your internists. And they said, holy cow, since we're responsible for taking care of the bulk of these young people, we've got to start getting together and figuring out what we're going to do. And they authored, and I was privileged to be a consultant on this, authored a consensus statement, a clinical guideline to say, okay, this is how we are going to come together and say that we're going to help transition these young adults into the adult healthcare system. In particular, though, and this is like the easiest slide ever to read. Okay. So where's this slide? Okay, so this box right here, it's labeled 5A. This is an algorithm. You can see it's, very easy to read, but this was, to advance any sort of policy changes, any sort of a clinician behavior change, it starts typically with the authoring of this sort of consensus statement. It's a review of literature, it's experts coming together to say, this is what we need to do. And then from this, there's a host of subsequent actions that happen, including how to change how we train our physicians, including how we advocate for changes in reimbursement, in terms of advocating for different research studies to prove this is appropriate care. It all starts with this. So that's why these groups authored this, but in this box right here is where basically it says incorporate transition planning into chronic care management. Who knows what that means? Exactly. This was the fancy way that they said, well, we know that within all of the young adults, there are those living with special health care needs, and we know that those are going to have some unique needs in terms of coordinating and transition planning, but we're not sure what we're supposed to do about this, kind of getting to what this lady talked about. So in this paper, they said, we're going to put a call to action out to the other subspecialty groups, cardiology, pulmonology, endocrinology, neurology, and say, you come back and you look at what we say we're going to do and you tell us what you're going to do. And this paper was published in 2011. No one answered except neurology. And so neurology has, I'll talk about it, we've just put out our consensus statement, and that's where we finally have some very defined expectations for what a neurology or any subspecialty team could be doing to help you all in planning for this transition process. So we're very proud that we are the first subspecialty group to respond. This is how we did it. So we wrote I'm going to put up both of these. So again, we used a very collaborative interdisciplinary panel, including patients, siblings, caregivers, adult and child neurologists, med peds, social work, physical therapists, to say, how do we want to do this? And this consensus statement, it's open to the public. You can download it here. I'm going to go through it in particular. It includes 8 common principles, which are really 8 steps that all patients and families should be taking and should be expecting that their healthcare provider is taking with them as they prepare for transitions. Again, it's important because today we are living in a patient-centered healthcare system. And for those of us that believe that, we're the early adopters of that thought, which means if we want change, we should drive the change. And that's really a reason I believe Nicole asked me to come here and speak to you about this paper and the meaning of it. We are also educating right now the physicians on these 8 steps. But in case you or your patient groups go in to meet with, let's just say, a child neurologist, and they say, we don't know what you're talking about, we want you to know about this paper and what this paper means and what this paper says, so you can bring it to their attention and say, let's work on this together. You can educate your provider just like your provider educates you. It's a true partnership. It's important when you are advocating for yourself with the transitions to understand that this statement has been endorsed by every major leadership body in our nation: the American Academy of Neurology, the Child Neurology Society, the American Academy of Pediatrics. This is the gold standard. Within it, like I said, there's 8 common principles, and then because we wanted to show how these 8 steps can be applied to any disease state, we wrote 5 clinical vignettes. So we chose 5 disease states, and those are epilepsy, Fragile X, ADHD, tuberous sclerosis complex, and muscular dystrophy. Okay, so let's start talking about these common principles. What the heck do they say, and how do they apply to you? So here's our case study that I'm going to use as we walk through, and I wasn't sure which disease to pick to use in this case study, but I thought with the latest news of what's going on within muscular dystrophy, and that's exciting for that new approval of that medication, we're going to go with them. So I don't really like when people read to me, so I'm not going to read to you, each line to you, but in general, we're going to look at Luke, who's a 12-year-old young adult, and he's diagnosed and living with Duchenne muscular dystrophy. In particular, he does see a child neurologist in a university-run center, and he also goes to see a rehab specialist. because of his changes in his tone and his muscle tone and how his body moves. He does go to school. He uses adaptive equipment to help get him around, and he is independent but does need some help just with basic activities of daily living like toileting and showering. His mom is his primary caregiver. She does have some assistance by his stepfather, but right now they aren't receiving any other community-based services. Okay, common principle 1, and this goes back to what I talked about in my very first slide. It's setting the expectation. So the first common principle that we are telling child neurology teams to do is to actually sit down and discuss with every patient and their caregiver that they should be expecting to transition to the healthcare system. And that needs to happen by their 13th birthday. And it needs to be documented in the chart. And you're going to see a lot about documentation because we're building this thing that you're going to hear about called a transfer packet. Why do you think that we said by the 13th birthday? Does anyone think that's really too early or too late? What do you think?
I think at that point, the child's old enough to like be taking their medications. They're old enough that they should be taking their medications on their own. They should know what medications they can really identify and start to build that independence.
So really talking about they're actually becoming more independent within their care management. Anybody else have a thought about why we chose 13? So typically, oh, go ahead.
Is it because in the schools, they ask you for transition age with looking at transitioning to in the schools, as a former coordinator of transition for
Okay.
education,
Uh-huh.
we had to start young to at least talk about adult services, that once you leave school, are you going to go on to college, work study, maybe a day-hab program, something like that. So maybe they're trying to align those ages.
So we definitely looked at exactly what the school system was saying, and that can vary, 14, sometimes 16. But the big reason, along with trying to coordinate with the school system, is so globally we think that a patient will leave the pediatric healthcare system at age 18. But like I said earlier, sometimes they're staying until they're 26, sometimes 21. And there can be a lot of coordination that needs to happen and a lot of different people that need to interact in order to make that appropriate planning possible. So we say start at a minimum of 5 years out, 13 years if you're going to be transitioning at 18. Okay, that tells you, again, thinking back to when I was defining the terms, transition is a process over many years. It should not be a one visit, here's a list of providers, thanks so much. So let's talk about how this happens. All right, here's Luke. And the child neurologist has this conversation with Luke and his mother in the room. They both say, let's shoot for 18, let's set a goal of 18. They get an actual written policy that defines how the clinic is going to help them in this transition process and walk along with them. The other thing I think that's really important to highlight, and it talks about getting to the difference in the culture of the pediatric to the adult healthcare system, but that a child neurologist sets the expectation in front of that caregiver that here forward, non-acute visits, there will be a portion where that child neurologist talks only to Luke, one-on-one, and the mother or the father or the caregiver will be asked to leave the room. That can be a total freak out. Has anyone ever had that happen? When I was in practice, I had that experience, and some caregivers were really caught off guard by that and thought maybe something secretive or, why are you asking me to leave the room? But it's starting to prepare this young adult that he or she will be navigating and caring for their care needs by themselves, and they should be able to explore a one-on-one dynamic with their care provider. So again, expect to transition. That's like the number one take home. If you remember nothing of what I say today, just please be remembering that transition is to be expected. All right, common principle number 2. There should be an annual assessment of the youth's self-management skills, and those annual assessments should begin at age 12. And again, recorded in the medical record. And the importance about this, again, is when we're talking about self-management skills, we're talking about, do you know all of your medicines? Do you know how to pronounce your medicines? Do you know your doses? Do you even know how to call in a refill or where your pharmacy is? Again, when we went back to our authoring panel, a lot of the patient advocates talked about, oh man, I ran out of my medicine because I didn't even know where to call or how to go get it because my mom had already done it for me. These self-management skills can even get as sophisticated as who's your insurance and who's your case manager, how do you advocate or how do you access your insurance. So it's important for the child neurology team to be assessing where each patient and family are at with these self-management skills. And from there, that leads to the development of the transition plan. I'm going to jump to number 3, and then we're going to incorporate it back into the case study together. But Common Principle 3, again, just talks about there should be phased transition planning every year, non-acute, so not when the symptoms are out of control, not when we're in crisis freak-out mode, when things are going along according to plan. There needs to be a sit-down visit where we again look at, okay, what did we assess on those readiness, those self-management assessments as needs? And how are we as the child neurology team helping that young adult and caregiver address what those needs are? And here's some examples of what can be included within that transition planning. So we've talked about medications and what are side effects, what are adverse effects. There needs to be conversations about reproductive health and possibly even decisions about birth control. Let's talk about, these are teenagers. These are people that are ready to do risk-taking behaviors. So let's educate them on what happens when you're on, let's say, a medicine for your muscles to relax, and you go to a party and you drink a beer. What happens? Let's talk honestly about that, right? Because that's a reality. And then, of course, the emotional and psychological aspects of living with these diagnoses. Okay, so let's talk about what's going on with Luke. I'll give you a second to read it through. You see over the next couple of years that his disease is an evolving one, and so we start to see some more progression of that disease and loss of motor function, and an acknowledgement of how is that those losses of those skills going to affect Luke and how he manages his own disease, and how does that matrix up to his goals of care. How many of you have heard the term goals of care? Does anyone have a clue what I'm talking about? You want to go for it? Yeah.
My doctors always have that in my chart.
At the end of all my appointments, I don't know if anyone else has my chart with Epic, and there's a printout, and there's like goals and like kind of a to-do list almost of things I need to do before the next appointment, and then where we want to end up, and like what the goal of the treatment is.
Where we want to end up, that's the perfect synonymous way to say that. A goal of care is, what do you want from your care? How do you want it to look? How do you want it to feel? Who's a part of that? Who's administering it? Who's not? Again, when we're talking about we are living today in a patient-centric healthcare system, you should be able to clearly outline for your provider what your goals of care are at, and then your care treatment plan should reflect those goals of care. So in particular, let's think back to the last visit with Luke, right? And he said, I want to be transitioned by 18. I'm thinking about living in a group home. Those are my goals for my life. So how does my care allow for him to get that way? And then by being clear about setting what those priorities are, you can see that they're able to have conversations and planning for what sort of adaptive equipment are they going to need to start sizing him for, getting insurance to pay for it, getting it delivered in order to enable that. Per his readiness assessments, it was assessed that Luke doesn't really know too much about his medications and needs some help with that and how to refill. So that, of course, was noted and then addressed. All right. Number 4 really gets into the fact that in the adult healthcare system, the patient makes their own decisions. But we know that we have young adults that are living with conditions that do impact their cognition. And so what is their competency level to be their own decision maker or not? And so what we've documented here is by 14, that sort of assessment and conversation needs to begin to happen with the young adult and their caregiver. If a patient is assessed to not be able to have their legal competency, then of course a host of actions have to happen, including guardianship. And I just want to talk for a second. I see on the agenda there's other breakout sessions with lawyers that will be talking about guardianship, but does anyone have a story they want to share about guardianship or have any comments about why this is so critically important? Yes.
Knowing, like what you said before, when your son turned 21, there are instances where the doctors didn't want to talk to me until I had guardianship. I was just talking about the importance of having the guardianship until I had it after my son was 21. Sometimes it'd be a real struggle to get the things done that I needed to get done. Medically, so.
And it can take years, and it does involve the legal system, so it's a whole new thing to navigate. And yes.
I'm really glad you asked this question because I'm sitting back here listening to this and saying, this is all really well and good, but how do the social services play into this? So I have a 19-year-old daughter, and she's cognitively a typical adult, but she is in a full wheelchair, needs 24/7 care for her all daily living tasks. And my husband and I did not want to take away her independence. We want her to be able to make choices about her medical care, and she's in college, she lives in the dorms, but she needs a lot of help. And even though I have a power of attorney that my daughter agreed to for education, financially I can help her, with just understanding how to pay bills on the website and everything. It's very difficult, like she was saying, it's very difficult for me to help her with her services. And I'll give you an example of last week. We were called by Medi-Cal. We live in California. And I was called to set up an appointment that the case manager was going to come and do a yearly assessment for my daughter. And I said, okay, well, I live in San Diego, but my daughter's in Los Angeles. That's where she goes to college. And I know that her case was changed to Los Angeles because of her moving there. And they said, well, you need to be at the meeting too. And I said, but I live in San Diego. And she's completely independent. Like on paper, she's supposed to be, like, this is what it's all about, right? I'm supposed to keep her independent. And I just spoke to them yesterday, and they said they have to talk to their legal team because I have to physically be at the meeting. Even though she's 19, I still need to be there. So how did the social services come into play with all of this?
Yeah. Yeah, that's exactly right. Every state is different, so I don't want to come across here and say that I'm the national expert on guardianship by any means, but typically at the age of 18, that is the legal designation for an adult. So I'm interested in maybe how your power of attorney or if you have a surrogacy documentation reads that maybe the state is misunderstanding. If she's an independent adult, then it's interesting that they're requiring you to be there. Independence, can have a range of definitions. She can be living independently, but you still have the authority to make her decisions. And perhaps that needs to be clarified to social services. Mm-hmm. That's usually based on insurance, but if she's on Medi-Cal,
And we actually just took her off of our private
uh-huh.
because the private insurance paid for nothing. So we let her be on Medi-Cal and California Children's Services because that's who pays for everything.
Do you have a clinician you can involve in this conversation that can attest to the fact that she's competent to be making her own decisions? So I would, if you have documentation from that clinician, which is really, that's what this talks about, I would bring that up to whoever you're talking to. It sounds a little bit to me, and again, I know I'm being recorded, so I probably shouldn't say this, but, they might just be trying to cover their, what. And so you having your ducks in a row and showing them that documentation will let them off.
My daughter turns 19 today.
Happy birthday.
And we got guardianship last fall. And when I say we were advised legally just to list my wife is technically the legal guardian, because otherwise both of us would have to be there for everything,
everything.
sign off on everything, which leads to the emotional impact of things.
Yeah.
For me, that was a strange feeling, because we've been a team the whole way to not be legal guardian, and secondly, in the court hearing, to have our daughter declared incompetent as a mom. My wife had to testify basically about as much bad stuff as you can imagine about our daughter, and had to work through that too. So just a comment.
Lots of layers to it. Yeah. Yes.
Yes, I know. My son will be 15 at the end of December, and he was put in. I had to place him into a residential facility when about 2 years ago. So he was just turned 12, which was, as any parent can imagine, that is horrible at 12 years old to have to, send your kid off to live somewhere else. But it was the best thing for him, and he's doing fantastic, and
Good.
I couldn't be happier. And I'd recommend it for really any parent that was in my position. It was the right choice. But my question actually goes back to where I know, because I'm from New York, and he's got Medicaid, and he's still under our insurance, and he will be, I guess, till I think like you said, 26, I think is the age where they can't be. Either way, he'll always have Medicaid. But as far as guardianship goes, like he got placed into a different house that he was in before. It's a smaller house because cognitively he's doing better. And at 18, that's when they'll start looking for the adult placement. So that gives them 3 years, because at 21, that's when they go into an adult program. So it gives them 3 years to, I guess, find the appropriate, program. And if they can't, then he'll stay there, because there's one adult in the house who's 23, because there's no openings where he needs to go. But as far as being even though he's there in that school, in that program, and he'll probably, I'll probably keep him there even in their adults program. Do I need to, when he turns 18 or 21, get that, what is it, like become his, take the guardianship from him so that I can make all, the medical decisions like we had just talked about, like even though he's there, and is that something I still have to do even though he's in a residential facility? I'm not, I have no idea. That's why I was just. Yeah, because I know I don't want to. At 21, he doesn't speak. He can. He's like, he's going to be 15. He's like a cute little 8-year-old running around.
Yeah.
But I don't want him to be someone to say, okay, well, Nick, do you want blah blah blah? He goes, oh, sure, cookie. Like, he asks for a cookie and think, okay, and
Sure.
that can't be. I don't, but I don't know if
Right.
that's something I have to still do, even though he's that.
It's a great question. I was actually just out in Denver speaking with, at a family conference for those living with Lennox-Gastaut syndrome, which is a very rare catastrophic form of epilepsy. And I had a mom from California, a similar situation. I only have 5 more minutes. Okay. That basically she was being told by her hospital, there's no need to fill out any of those forms. We know Joshua. We'll always talk to you about Joshua. And my recommendation, and I'm sure I see a lot of reaction in the room to your story, is don't be dependent on a facility or a house to be able to tell you what you can and cannot do. Yeah, so I would talk with your healthcare team and start talking about what's our goal of care? Do we think that your son can be competent enough to make his own medical decisions? And if you and your healthcare team say no, then we've got to start working on the documentation.
Because it can always be taken, let's say, like right now, I'm saying no, absolutely not. But let's say in the future, as he gets older, and becomes, maybe with his syndrome, because he's got, whatever, his genetic, he just all of a sudden, I can always.
Exactly, and that's exactly what we're talking about, that needs to be, this conversation needs to start at 14. It needs to be continually reassessed, because things can change. So I'm sorry, I'm going to just, okay, so this kind of talks about Luke and how they navigated that. One thing I wanted to also highlight on here, and especially when we're talking about appropriate documentation and goals of care, We know especially with rare conditions, there can be exacerbations that can be very life-threatening. And so making sure that appropriate documentation is in place for what the patient and the family and the caregiver are thinking about, things such as trachs, DNR status, etc. Because we want to make sure that the care is always delivered in accordance with your goal of care. All right. Very quickly, the transition plan should be comprehensive, meaning that we're looking at more things than just who's taking care of them, and we've really talked about that today in terms of thinking about education and vocation and where they're going to live. This also starts talking about the fact that you can see at the bottom, at the individual part of the clinic visit, that child neurologist is starting to talk with Luke about some risk-taking behavior, including substance abuse. Again, to make sure that we are maintaining as high level of health as possible. Comment 6 talks about the fact that the neurology team is responsible for the neurology component of the transition plan. So this transition plan could be talking about a bunch of specialists, PCPs, but the neurology team is going to own the fact that they need to make sure the neurology material in this transition plan is up to date and reassessed annually. And a transfer packet is then built. So this transfer packet could be as old school as handouts, could be a folder, could be if you're on Epic and electronic health records and you're going to be in the same healthcare system, this is all shared electronically. But what this talks about is we heard loud and clear from families and patients, if you're going to make me go to a whole new team, I can't be responsible for remembering every test I ever sat through and every medication I ever tried. We need that information to go with us. And so this is helping those patients and families not carry that burden by themselves, but the child neurology team helps prepare that packet, and it goes with you. Number 7 talks about you shouldn't be on your own looking for which adult provider to be going to. This again starts at least 2 years out from the actual transfer of care, and that team is helping you coordinate that transfer. So number 1, is there an adult provider that is willing to accept your case? Does that adult provider need some education on your condition? Can you access where that adult provider lives? And that's really where this part of the case study talked about. Initially, they were going to transfer Luke to an adult provider that specialized in DMD, but that provider was an hour away, and transportation, that just wouldn't work for Luke. So instead, they found a provider, an adult provider, inside the same medical center, but maybe was not as familiar or comfortable with his rare condition, so that child neurologist said, hey, I'll stay on as a consultant for a year. And that's actually a model that we see a lot going on within child neurology, is as long as they know, hey, you're around for a phone call if I need to review this medication I'm not familiar with, adult providers are becoming more agreeable. And the last one talks about the fact that child neurologist and their team are having direct communication with the receiving team to make sure that they've got the information they need, the transfer happened, and the family is satisfied. So here's the last sort of case study about that. I'm sure we're up against time, but I think it's really important. I always like to end with, what do you do on Tuesday? You know, I don't know about you, but I come to these conferences, I eat way too many carbs and probably drink a little bit too much wine, and I talk too much, my throat gets sore, and I get home on Monday and I'm like, oh my gosh, I can't do anything but just check my emails. But on Tuesday, I'm ready to take the lessons from the conference and put them into action. So on Tuesday, what can you do following this session? Get more informed. These are 3 websites you can go to that specifically give you transition information on tools and resources. The first one is ours at childneurologyfoundation.org. I'm going to quickly do a promo. This is our site. If you've ever been to it, when you go to the homepage, you're going to self-diagnose. Are you a patient or caregiver? Are you an advocate or you're a clinician? Once you hit that button, it ducktails you into specific information. And we have a whole page just on living, approaching transitions into adulthood. I encourage you to go. The other ones are gottransitions.org. That's a national center completely dedicated just to transitions. And medicalhomeinfo.org. That's a national center for children and youth living with special health care needs, and they have a whole transition section. begin doing some conversations within your family, within your patient group, and with your clinicians about what your expectations are for transitions and where are the gaps and where are the easy low-hanging fruit you can keep moving on about this. And take that neurology statement that I showed you where to download to them. The bottom line is to remember, this is complex. This is a beast, to use my term. You aren't in it alone. It's not going to happen overnight. But there's lots of people looking at this. There's lots of people that want to help you, so you're not alone. Just remember to reach out and ask for help. And that's really, again, why the Child Neurology Foundation is here. We really want you to know that you're not walking alone. And even if you have your condition that you are living with or that you're here representing has nothing to do with pediatric neurology, please always think that you can reach out to us. And if we can't help you, we will find those within the country that can. And that's my email. Feel free to always, reach out to. Yes. Yes.
Pediatrician versus your internist. It seems like in a lot of ways you can almost get, like an ophthalmologist to talk to an ophthalmologist. Or
Yeah.
neurologist to talk to another nephrologist, or some of these specialties. I always considered my pediatrician the gatekeeper.
Good.
And soon after 18 years, the pediatrician, knew what Wagger stood for and all the complications that could arise with it and everything else. And in trying to find a good internist, and I've been trying now for 8 years, it's just, is there a good way to try and educate an internist as to what has been going on and, with a rare disease that they've never heard of?
So I'm not an internist, so I'm not sure, but in terms of trying to change clinical behavior, the one quick thing I would say is you've got a good relationship with your pediatrician who's very well informed on this rare condition. Ask him or her, who's an internist that you have a good working relationship with, that you would be willing to serve as a consultant to help them get more comfortable with this rare condition. And that is a strategy that we are seeing these adult providers a little bit more receptive to. I don't know if that helps. Yeah.
Your personal interest, sometimes that's a transition plan that a lot of families take.
That's a great point.
A lot of personal stuff. You thought that, wow, you didn't think. So not in your case, but as your friends, their interest.
And then actually my friends went to the concierge and so.
My mom used to always say to me, birds of the same feather flock together, and clinicians that are a little bit more comfortable working with rare conditions or children youth with special health care needs typically are drawn to peers and other subspecialists that are like-minded. And so sometimes it's just an attitude set point is what you're going back to. And if they're okay to kind of step into the gray with this lifeline, phone a friend over to your pediatrician, that might be a bridge. Thank you all very, very much. Thanks so much for coming to this conference, and I applaud the work you all are doing.